back to the series of online lectures about thyroid medicine with Professor Duncan Ferguson from the University of Illinois. Welcome. What's the topic today?
Today we're going to talk about how you confirm the diagnosis of hypothyroidism. And we'll go through a few tests and sort of show how we put it all together. And I first want to give credit to a group of people that worked on this about 10 years ago, but things pretty much have stayed the same in vet medicine in terms of the tests that are available and how we interpret them. So we have just 10 more years of experience. But this was based on the Society of Comparative Endocrinology's group, names listed here, who thought about how they wanted to make a recommendation for best practices. And just so we make sure we have all the acronyms in mind, we talk about this. We have total T4, we call TT4, total T3, TT3, free T4, and I want to focus on the type that we are actually analyzing in the study, which is dialysis method, free T4, FT4D, T4 autoantibodies, T4AA, or T3 autoantibodies, and then thyroglobulin autoantibodies. We won't talk about in this unit, but we'll talk about when we talk about autoimmune tests, and then TSH.
Does this mean it's quite the same as an intracellular FT4, the dialysis method?
The dialysis simply is the way we do it. Separate. We'll actually go through that again just briefly to show how we measure the technique, but it's a simulation of what's going on in the plasma, not inside the cell. So the first thing is to note why FT4 is important, and this is we talked about it in our physiology unit, if you remember, that was a key concept for a clinician, and that in dogs and cats, and we're focused on the dog today, about 1 part out of 1,000 is free. And so this is the part that actually correlates when you measure it alone, and we'll show you the data, it actually has the greatest specificity, sensitivity, and accuracy of any single test, but we, as I said before, don't just measure one thing. It correlates with clinical status, and that's important for the clinician. And as I said, there are techniques that we could use that are borrowed from human medicine, that are direct assay methods, that aren't as accurate and have to be proven for even the correlation to the gold standard, which is free T4 by dialysis.
Are these tests we can do on our own in the practice, like these quick tests, or do we send them to a laboratory?
Yeah, for free T4 you have to send it to the laboratory. But total T4, actually those methodologies are now pretty much capable of being done in laboratory units for the practice. Okay, I'm going to take you back to the physiology unit. Remember, medicine, particularly in the endocrine system, is driven directly from physiology. And I'm not going to review much about what goes on at the top, except to know how important it was for predicting what's going on in the cell to understand free T4. But go down here to the in vitro, which is our measure of free T4, and remind you that we simply simulate this in a dialysis chamber and allow it to come to equilibrium. It takes about, this is why it's a technique that labs have to do. It takes 18 to 24 hours, 37-degree intubations. And then you measure free T4, often by a radial assay. And there are other techniques. But this is the technique I'm going to call free T4 by dialysis.
And for all those that couldn't remember what was happening with the binding proteins, there is a video clip that everyone can have a look at, and then we'll understand what's
Exactly. Always tied to medicine, to physiology. Okay, so here's some data, and this comes from this group that sort of analyzed a couple of important papers that were mixing not just hypothyroid dogs with healthy dogs, but also sick dogs. It's very important to put the real population that a practitioner sees together and then sort of figure out how good is the test. And so let's start with sensitivity of the test.
Could you explain that for some of us who are not that fit anymore? what does it mean, sensitivity, specificity?
Yeah, we're going to spend a lot of time on these first two. And I'll just characterize sensitivity as a characteristic you want in a test or a screening test. Okay, you want that test to have a basket or a funnel that collects everything, and in there is the truth, so you're not missing anything.
Okay.
And so that means if, and this is where we're going to look at it with T4 here, for example, that if T4 is normal, remember that if it's normal, then you can rule out hypothyroidism. But the converse, which is if T4 is low, you can't rule it in.
Okay.
And that's, so we're going to look for a sensitive test that keeps it in there into that basket if it's appropriate. So sensitivity, let's focus on, and then let's talk about specificity, and then we'll talk about the number. So specificity means that the diagnostic values are in the normal range. So if the diagnostic values are in the normal range, then that means the animal is not hyperthyroidism, it's not hypothyroid. Okay? That's what specificity means. So for a confirmation test, we always want high specificity. And so you see, so let's turn to total T4. If we're going to be in a practice, and maybe you have it in your lab panel, and you measure T4 in a dog, first of all, I'm going to go back to some concepts that we talked about before, that you always want to have clinical signs. They always improve your diagnostic testing value. So you say, I think the animal's hypothyroid, take a T4. And if the T4 is normal, okay, in this study it would say almost 90% of, you have almost 90% certainty of ruling it out. You're ruling out hypothyroidism. And the other study actually the number rose almost to a perfect number, 100%, when they took out animals that had something that would alter the T4 because they have antibodies. And this is the most common disorder in dogs is autoimmune thyroiditis. And autoimmune thyroiditis in a very small subset of animals will produce T4 autoantibodies that makes the T4 assay worthless. So when they took those out, they found that number, the true measurement of total T4 in this case, actually, if you ask the question the right way, is T4 normal? And if it is, then you rule out hypothyroidism. That makes it a good screening test. It was almost a perfect screening test in that circumstance. Specificity, you see that T4 can be low in circumstances like illness, and that's why the specificity is a little bit lower. Now, if we add free T4, and counting free T4, which is measured as a clinician, and you can see one of at least this study showed significant improvement as a single test for the screening process, but also for specificity. So if free T4 is high or if it's low, usually you'll say, well, it's not a normal animal. That's what we're saying with specificity. And also even accuracy, so the reproducibility, putting the animal in the right category, it also is pretty good in all three categories. So
where does it result in that we have here just this 80% when we took out those cases?
yeah, that's interesting. And that's interesting in that case that it kept the specificity up, because remember what I told you, in the physiology, one of the indications for measuring free T4 at all is when you have something that disrupts binding, and those antibodies, the T4 that produce an autoimmunity to an autoimmune thyroiditis, basically make the total T4 measurements worthless. And yet they're filtered out, if you go by that membrane, and the true value of T4, free T4, comes out in a dialysis system. So it didn't improve the sensitivity, but the specificity is good. And they're just two different data sets. So to kind of summarize this, so total T4 is normal. Let's just use the idea that you're not measuring total T4 antibodies. About 90% of the case you can rule it out. That's important. It gets you a long ways. If T4 is normal and you have, like I said, negative anti-T4 autoantibodies, that number can be even higher, depending on the study. And if free T4 is normal, you can rule out hypothyroidism in 98% of the cases. And that's why, as a single test, it sort of incorporates both the aspects of ruling out the antibodies and the T4 measure.
And is there a test to see if these are negative?
Yeah, unfortunately, that's something that's done in diagnostic labs that requires radioactivity. And so those labs aren't comfortable with that or don't have the capability, you know, it's true in Europe. That's a little more difficult to come by. Although that was the study that looked at that was in Europe and the UK. All right, so what about TSH? TSH, go back to our physiology unit, was the sort of the pituitary gland regulator of thyroid function. And it's been a test that's been used in human medicine as like a screening test. It's a very good screening test in people. Now let's look at it in the dog. So using our same criteria, you can see that somewhere about 1/4 of the dogs with a normal TSH can still be hypothyroid. That makes it a poorer screening test. In humans, it would be about 100%. So the question is, why is that? And that's something that we kind of wonder about, and we'll talk about that later. Specificity, you can see what TSH does by itself. It improves specificity, so that if TSH is high, you think hypothyroidism. Unfortunately, the test is not good enough to tell us about low, being hyperthyroid is not sensitive enough. But if it's normal, it's okay. What the main value that TSH brings to the table is when you link it with T4 or free T4, and it almost doesn't make any difference which one you do.
It's making it worse.
It makes it worse at the screening test, but for the actual specificity, the confirmation test. So for example, if you measure T4, you found it to be low, and then you measure TSH. Well, that's a very good indication of hypothyroidism. There are very few things that falsely elevate TSH. And just remember, the question is different for a screening test. What tells us about normal? And so you can see the same kind of values with free T4 and TSH. Good confirmation. Confirmation tests are based on their specificity. Okay. So basically, TSH adds specificity to T4 or free T4 being low. It's a poor screening test because this percentage of animals that are missed because of that. And there's a couple of reasons for this that are interesting that it made the dog different than the human. TSH, it turns out, seems to increase for a while, but chronic hypothyroidism, it eventually goes down. We don't know if there's exhaustion, we don't know if it's just some alteration in receptor sensitivity to the pituitary. It's not clear. There's also known to be pulsal release of TSH in the dog, but those pulses don't go far enough probably to explain the fact that some of them are so low that they're normal and not elevated. So free T4 and TSH become more interesting to us, particularly if you're dealing with a sick animal, because you have an animal that's got other illnesses or it's got drugs on board. And I just wanted to list out here some of the more common drugs that can mess up thyroid function testing. Glucocorticoids in high doses particularly will lower T4. We think also, although it's hard to tell because the assay is not sensitive, we think it also probably suppresses TSH. Free T4 doesn't tend to fall quite as rapidly. Sulfonamide drugs are actual goitrogens. It means they interfere with thyroid hormone production. And so it actually, what I would say, causes hypothyroidism. T4 falls, TSH rises, free T4 falls. Phenobarb is a little bit trickier, and it's interesting because a lot of people have thought that epilepsy, which is used, treated by phenobarb, thyroid status. I think it's very complex because the drug that's used to treat epilepsy can actually lower T4 values. And most of the time TSH stays normal, which should be our clue that the animals themselves are not hypothyroid. Non-steroidal anti-inflammatory drugs basically are the sort of prototypical kind of drug that is highly protein bound and will interfere with the binding T4 in the serum, and therefore what will happen is it will increase the free T4 fraction, and free T4 will stay normal, but total T4 may fall. And so that's what we see, and TSH usually won't change very much. And the only situation we've seen a fall with TSH is carbohydrate, that it's very difficult to determine what the physiological or medical significance is. And ankylopenia is another study that's been done where there was a fall in T4 or free T4, but TSH stays normal, which suggests the animals are not hypothyroid, but they're euthyroid. So most of these drugs, except for sulfonamides, do not cause hypothyroidism. They just mimic changes in T4, which is one of the reasons why the screening test, it's important to think about T4 as a screening test, that only when it's normal can you rule out hypothyroidism.
Which means we have to remember for our protocol, we need a very good analysis on the medical history to see how to work with the results of the screening test.
Yeah, for a lot of veterinarians, talk to me about this, give me lab data to look at, and I'll say, well, what does the animal look like? And if the animal's sick, I said, well, it's probably not going to die of hypothyroidism. So you can wait and do the diagnostic testing later. Yeah. So in summary, free T4 by dialysis is a single test that has all the three characteristics we talked about in assay needing to have. And it has the best screening sensitivity and specificity for confirmation are pretty high. Now most people don't start just measure this because we highly recommend that you measure two things, not just free T4, but I just wanted to point that out, and the data supports that. Free T4 definitely should be considered when we have these complicating factors of illness involved, what we call non-thyroid illness, or the presence of the drugs, which we just talked about, or the presence of those antibodies, which we talked about how it was a small percentage of animals with autoimmune thyroiditis. So these things, free T4 can help sort out. And then finally, TSH by itself is a for screening test. That's unlike humans where people are screened, babies are screened at birth with TSH because it's such a good screening test for hypothyroidism. But in dogs, it turns out we have about a quarter of the dogs whose TSH will stay normal even when we can prove otherwise that they have hypothyroidism.
For a protocol or our routine, it should mean that we need the clinical science, we should know about the medical history, and then start with the screening.
Absolutely.
And afterwards do the confirmation or do it both together. We first look at the screening and then...
Absolutely, yeah. And I think I'm not a big proponent of, in the dog, of having geriatric, T4 added to a geriatric screen, because there isn't that, what you just said, there's not a suspicion of hypothyroidism in first. It turns out that hypothyroidism is a disease of middle age, it's not a geriatric disease in the dog. And so I think in that circumstance, it's always better to have the diagnostic suspicion than do your testing. And you could do T4, as we pointed out, as long as you ask the question about it, which now I think you can do. And so finally, we get to confirm it, usually with TSH. Most people are probably doing T4 and TSH. And there are even some labs that do what are called reflex. So if T4 turns out to be low, they'll automatically do TSH for you at a little bit additional cost. And that sort of reflects the idea that if T4 is normal, you can stop. It's not hypothyroid. So if you have diseases, we said already that, I think it doesn't make any difference from a statistical standpoint whether you have T4 or free T4 measured. But when you have chronic illnesses, the drugs, etc., I would probably lean towards, or any question after T4 is measured, as well as TSH, I would measure for T4.
Thank you very much. It was Dr. Ferguson. Now we got into the clinic.